Okay, Bismillahirrahmanirrahim. Okay, my name is Nurul Hanisah Binti Bakar, and good morning to my Miss Faika and my fellow friends. Okay, so today I'm gonna evaluate the image evaluation of AP and lateral ankle. Okay, okay. As you can see here, this is a foot position during the projection of ankle. So this is AP view. So this is the outcome of the AP view of the ankle, and this is the lateral foot position, and this is the outcome of the lateral view of the ankle, and this is additional because this is a special projection for ankle. Okay, for this evaluation I will focus on this lateral and this the AP projection only. Okay, this is a criteria of a true AP ankle. Okay, the first one is medial mortise. Okay, as you can see here, medial mortise is here. Okay, which is the tibio-talar articulation. The tibio-talar, which means tibia, and the talus articulation means by where two bone meets. Okay, this is where two bone meets. Is appear open. As you can see, this is gap here. And the second point is lateral mortise, which is here. Okay, the fibulotalar, fibula, and the talus articulation appear close. Okay, okay. For the third point, distal tibia. Okay, distal tibia and talus partially superimposed with the distal fibula. Okay, this is the distal tibia, and this and talus. Okay, I'm sorry, this is talus and this is distal tibia superimposed with the fibula, with the distal fibula here. Okay, this is the superimpose. Okay, the fourth point is tibio-talar joint is at the center of the collimated field. Okay, tibio-talar joint is here, this joint here. Okay, at the center of the collimated field, and include 1/4 of distal tibia and fibula, and talus and the surrounding ankle soft tissue. For the fifth point, tibia is demonstrated without foreshortening. Okay. Okay, as you can see here, this is an AP ankle. So how do we detect the rotation on the radiograph? Okay, the first thing is we must evaluate the medial mortise. Okay, medial mortise is which is here. The medial mortise or tibio-talar articulation must be open. Okay, okay. For the second thing, we must evaluate the tibia and talus superimposition of the fibula. Okay, this is tibia superimposition with the fibula, and this is the talus superimposition with the fibula. Okay, this radiograph is actually medial rotation. Also, we call it as a internal rotation or also mortise projection. Okay, as you can see in the radiograph, fibula, lateral or north-talar superimposition, which is here. In this radiograph is no north-talar superimposition, which means that lateral mortise open. Okay. The second thing is tibia superimposed less than 1/2 of fibula. This is so little, as you can see here. The superimposed is so less than 1/2 of fibula. The posterior tibia is also superimposed by the talus, and the medial mortise is close. Okay, this is the criteria of the mortise projection, medial rotation. Okay, so this is next rotation, which is external or lateral rotation. Okay, this radiograph is external rotation. Okay, as you can see, we must evaluate the medial mortise, which is must be open, As you can see here, the medial mortis is obscured, which is covered, and the tibia superimposes more than one half of fibula. This is fibula, and this is tibia. Okay. The tibial and talar superimposition, which is the medial mortis close. Okay. Okay. This is the difference between AP and mortis projection. As you can see here, for AP, the lateral mortis or fibulo-talar articulation appear close, and for mortis projection, the lateral mortis or fibulo-talar articulation appear open. Okay, this is closed and this is open. Okay, for AP, medial mortis is open. Okay, this is open. And for mortis projection, this is an extra info, which is the tibiotalar line, and the distal medial aspect of the fibula should be continuous. As you can see, this is not continuous, this is not mortis, and this is mortis because this line is continuous. Okay, the articular surface of the talus should be congruent, or which is consistent with that distal fibula. Okay. Okay, this is the criteria of the true lateral ankle. Okay, the first one is tibiotalar joint must be open. Where is tibiotalar joint? This is the tibiotalar joint. Okay, the gap here. Okay, the distal fibula and the posterior half of tibia is seen superimposed. Okay, distal fibula and the posterior half of tibia. It must be posterior half, not anterior half of medial of tibia. The fibula must be on the posterior half of tibia, seen superimposed. Okay, the third point is tibiotalar joint, which is here at the center of the collimated field and equated talus. 1 inch of fifth metatarsal tuberosity, or we call it a metatarsal base, and distal 1/4 of fibula and tibia, and surrounded by ankle soft tissue. As you can see here in this radiograph, this picture is taken from the internet, and the soft tissue is, as you can see here, this is cut off of the soft tissue region. Okay, the dome of the talus are seen superimposed. Okay, there is superimposed of the medial and lateral dome of the talus. Okay, this is info. For normal patient, must dorsiflex foot until long axis position at the 90-degree angle with the lower leg, and the foot in this radiograph is dorsiflex because this is 90-degree. Okay, this is a warning. Do not force trauma patient to dorsiflex the foot. Okay, just maintain the foot to be in the normal position. Okay, this is a rotation for the lateral ankle. Okay, we must evaluate the position of fibula and tibia. Okay, for the internally rotate of the foot, the fibula is seen on the anterior half of tibia. So this is the correct positioning of the fibula, which is fibula on the posterior half of tibia, which is in the radiograph. The fibula is seen anterior of the tibia. So this foot is internally rotate. Okay, the internal rotate this is the criteria. The forefoot is elevated and the heel is depressed. Okay, this is heel and this is forefoot. Okay, as you can see, the distal fibula on the anterior half of tibia. Okay, medial talar dome posterior to the lateral dome. Okay, how do we want to know that the dome is medial or lateral. Okay, actually, the lateral dome is quite closer to the fibula. So, the lateral dome follows the fibula when the fibula is projected anteriorly. So, the lateral dome is also projected anteriorly. Okay, that is how you define, how you going to know which one is medial and lateral dome. Okay, this is the second rotation, which is the external rotation of the foot. Okay, as you can see here, the distal fibula is on the posterior half of tibia, but the medial talar, okay, medial talar dome at the anterior part of the graph. Okay, as I said before, the lateral dome follow quite closer to the fibula. So when the fibula seen posteriorly, the lateral also seen posteriorly. Okay, this is lateral dome. Okay, for the foot positioning for the external rotate, the forefoot is depressed and the heel is elevated. Okay. Okay, this is a parallelity of the foot during the lateral ankle projection. We evaluate the position of talar dome or the navicular and the cuboid, okay, which means here or here. We evaluate these two. Okay, this is this radiograph is taken with the proximal leg elevated. Okay, what mean by proximal lower leg? Okay, the proximal lower leg is the area that closer to the knee. Okay, for the distal lower leg, which is the area that closer to the ankle. Okay, okay, which is the proximal above tibia fibula elevated. In this radiograph, there is visualized two domes, which is lateral and medial dome. The lateral dome is proximal dome. Okay, and the navicular, which here, this is navicular, superimpose most of cuboid. Okay, this is cuboid. Okay, as you can see here, the cuboid, which is so little here. Okay, this is the explanation of the proximal lower leg elevated. Okay, knee is not extended, which means the proximal fibula is elevated, not in the same horizontal line. So the lateral surface of foot is close contact to the cassette. Okay. Okay, this is the next parallelity, which is the lateral ankle projection taken with the distal lower leg elevated, which means the distal tibia fibula is elevated. Okay, it visualizes two domes, which is lateral and medial dome. The medial dome is the proximal dome, and the navicular here superimpose less of the cuboid. This is cuboid. Okay, as you can see, this cuboid is appear larger. Okay, this is the explanation. The knee is extended, but the foot is not at the same level of the tibia fibula, which means distal tibia fibula is elevated, and the lateral surface of foot is not close contact with the cassette. Okay, we continue with the epi projection of the ankle. Okay, this is epi ankle projection. Okay, this is because the distal fibula should be slightly superimposed with the distal tibia, and the lateral and medial malleoli of the distal fibula and tibia are in profile. Okay, The tibio-talar joint space should be open, yet tibio-talar joint should be open, yet the full mortise joint should not be visualized on the AP. Okay. On the calcaneum, the calcaneum is not in profile. As you can see here, the white line is the calcaneum that superimposed with the bone here. Okay, this is navicular bone somewhere here, and this is calcaneum. Okay. Okay, for the position for this radiograph is correct. This is because the medial mortise open and the lateral mortise is closed. As you can see here, the distal tibia and talus partially superimposed with the distal tibia. Okay, for the alignment, for AP ankle, the alignment between X-ray tube and cassette cannot be determined because there is no four borders of the collimation on the film. For the alignment between X-ray tube and patient also cannot be determined because there is no evidence of collimation on all four borders on the film. For the alignment between patient and cassette is correct. This is because the distance between the center structure to the edge of the film on the left and the right is equal, and the superior and the inferior level is also equal. The centering point for this radiograph cannot be determined because there is no evidence of collimation on all four borders of the film. Okay, for the standard centering point for this projection is direct to the mid-ankle level, mid-ankle joint at the level of medial malleolus. As you can see here, we palpate at the medial malleolus level because the lateral malleolus is way more inferior to the medial malleolus. So we take the CR or the centering point is at the level of medial malleolus. Okay, for the collimation, at the superior border, the structure that should be included are 1/4 of distal and tibia, 1/4 of distal tibia and fibula, and the medial malleolus. Okay, for the lateral border, the structure that should be included are 1/4 of distal tibia, 1/4 of distal fibula, lateral malleolus, and the fifth metatarsal tuberosity. For the inferior border, the structure that should be included are fifth metatarsal tuberosity, the superimposed calcaneum, and the metatarsal bone here. Okay, in this radiograph, there is no evidence of radiation protection apparatus seen on the radiograph. Okay, for the exposure factor, the cortical outline of the thin structure, which is the lateral malleolus, can be seen, and the cortical outline of the thick structure, which is the distal tibia, also can be seen. So the assumption is the KVP used is adequate. Okay, the bony tubercular pattern of the thin structure, which is the lateral malleolus, can be seen, and the bony tubercular pattern of the thick structure, which is the distal tibia, also can be seen. So the assumption is the MAS use is adequate. So as a conclusion, the KVP and MAS must be maintained. Okay, for the marker on the AP ankle, there is no evidence of anatomical marker shown on the radiograph. Okay, as you can see here, this is the example that I included on the radiograph. To improve this, place the marker on the superior or inferior side of the film and do not superimpose with any region of interest. Okay, this is the example. Okay, for the aesthetic, this film size, the film is cannot be determined because this picture is taken from the internet. So the film recommendation for this projection is 24-30 cm, which is sufficient to demonstrate all the structures of interest. As you can see here, this radiograph is no evidence of artifact. Okay. For the name, the patient name and ID, date of examination, place of examination are not visualized. Okay, to improve this, patient name and ID should be visualized at the appropriate area and do not superimpose with structure of interest. Suggested area, left or right, superior border of the cassette. Okay, this is my example. Okay, for the conclusion of the epi-anchor projection, this radiograph is not acceptable because the first reason is no patient name, ID, date, and place of examination. For the second reason is there is no evidence of plumber marker on the radiograph. Okay. Okay, we continue with the lateral projection of the ankle. Okay, this is the projection of the lateral ankle. Okay, as you can see here, this is the radiograph of the lateral ankle projection. Okay, this is the lateral ankle projection because the distal tibia, okay, the distal tibia is superimposed by the posterior half of the distal tibia, and the calcaneus is appear on the in lateral profile. As you remember before, in AP you can't see the appearance of the calcaneus because the calcaneus is superimposed in this region of bone. Okay, the medial mortis is cannot be seen because we only can see the tibiotalar joint here. The anterior and posterior aspect of the talar dome are aligned, which is anterior, and this is anterior, and this is posterior, are aligned. Okay. Okay, for the positioning for the lateral ankle, the positioning for this projection is incorrect. This is because the foot is in plantar flexion because this is non-trauma patient. Okay, the fibula is seated in the middle of tibia, suggesting that the toes are raised too far off the IR. Okay, to improve this, dorsiflex foot, patient foot, 90 degrees with the lower leg, and the reposition without the toes raised off the IR. Okay, this is the extra info. Okay, this is the projection of the ankle of the pediatric patient. Okay, because the epiphysis plate are not fused together yet, as you can see here. Okay, for the alignment, for lateral ankle, the alignment between extractive and cassette is cannot be determined because there is no evidence of collimation on all four borders of the filum. Also, the alignment between extractive and patient also, which is cannot be determined because there is no evidence of the collimation on all four borders of the filum. For the alignment between patient and cassette is incorrect. This is because the distance between the center structure of to the edge of the filum on the left and the right side is not equal. Okay. The centering point for this radiograph is cannot be determined because there is no evidence of collimation on all four borders of the filum. The standard centering point for this projection is direct at the medial malleolus, which is here. Okay. Okay, for the collimation of the lateral ankle, the superior border, the structure that should be included are one fourth distal of fibula and tibia and the articular surface. Okay, the articular surface is at here, not the gap but the bone here. At the lateral border, the structure that should be included are calcaneum, navicular, and the fifth metatarsal tuberosity. Okay, at the inferior border, the structure that should be included are the calcaneus, cuboid, and the fifth metatarsal tuberosity. On this radiograph, there is no evidence of radiation protection apparatus seen on this radiograph. Okay, for the exposure factor, for the lateral anchor, the bony cortical outline of the thin structure, which is the fifth metatarsal tuberosity, can be seen, and the bony cortical outline of the thick structure, which is the calcaneus talar, can be seen. Okay, you can see it. So the assumption is the KVP used is adequate. For the bony trabecular pattern of the thin structure, which is the fifth metatarsal tuberosity, can be seen, and the bony trabecular pattern of the thick structure, which is calcaneus and talar, can be seen. So the assumption is the MAS used is adequate. For the conclusion, the KVP for the marker, there is no evidence of anatomical marker shown on the radiograph, but there is evidence of digital marker. Okay, to improve this, place the plumber marker on the superior part of the film and do not superimpose with any region of interest. This is the example that I insert in this radiograph. Okay, for the aesthetic, this film size cannot be determined because this picture is taken from the internet. So the film recommendation for this projection is 24-30 cm, which is sufficient to demonstrate all the structures of interest. Okay, there's the evidence of artifact on the radiograph, which is the white marks on the soft tissue region. Okay. For the name, the patient name, ID, date of examination, place of examination are not visualized on the radiograph. Okay, to improve this, patient name or ID should be visualized at the appropriate area and do not superimpose with structure of interest. Okay, suggested area is the left or the right side of the superior border of the cassette. Okay, this is my example because this space seem to be more wider. Okay, for the conclusion of the lateral ankle projection is this radiograph is not acceptable because there is no patient name, ID, date and place of examination. For the second point is there is also no plumber marker on the radiograph. Okay, this is all my references to complete my evaluation. The first one is the website that I used to further reading. Okay, this is the Bone Ranger textbook that I use, and the third is the handbook of radiographic positioning, and the fourth thing is McCullen, which is radiographic image analysis, and the fifth thing is the link that I use to further reading the lateral ankle projection, and the lastly is the pocket book guide of radiographic image evaluation, which is the Haji Nazri book. Okay, that's all. Thank you.